Welcome to Pulse and Pressors, where critical care gets crystal clear. Anterior STEMI is the classic pump failure infarction. It occurs when the left anterior descending artery, the LAD, acutely occludes and cuts off blood flow to the anterior wall, septum, and often the apex of the left ventricle. This region is the power core of the LV. When it fails, global systolic function collapses, and the patient is at high risk for cardiogenic shock, malignant arrhythmias, and mechanical complications. On the ECG, anterior STEMI is defined by ST segment elevation in the precordial leads that look at the front and septal aspects of the heart. ST elevation in V1 through V4 signals anteroseptal involvement, reflecting infarction of the interventricular septum and the anterior LV wall. When the ST elevation extends laterally into V5 and V6 and up into leads 1 and AVL, the infarct is more extensive, anterolateral or large proximal LAD territory. Inferior leads 2, 3, and AVF typically show reciprocal ST depression, which strengthens the ischemic diagnosis and separates true infarction from benign early repolarization. Understanding the coronary anatomy explains why anterior STEMI is so dangerous. The LAD runs in the anterior interventricular groove and gives off septal branches that dive into the interventricular septum, as well as diagonal branches that sweep over the anterolateral left ventricular wall. The septal branches supply not only myocardium, but also the His-Purkinje conduction system, including the bundle branches. A proximal LAD occlusion therefore jeopardizes a large amount of contractile muscle and the electrical wiring of the heart at the same time. Distal LAD occlusions may be more localized to the apex, but can still significantly reduce LV function. Hemodynamically, anterior STEMI is dominated by loss of left ventricular systolic function. The injured anterior wall and septum become akinetic or dyskinetic, which reduces stroke volume and cardiac output. The body responds with sympathetic activation and vasoconstriction, so systemic vascular resistance rises in an attempt to maintain blood pressure. However, as contractility falls further, mean arterial pressure declines, end organ perfusion drops, and cardiogenic shock can develop. On invasive monitoring, the cardiac index is typically low. Pulmonary capillary wedge pressure is elevated because the left ventricle cannot effectively eject, and SVR is often increased as a compensatory response. Clinically, the patient appears cool and clammy, with hypotension, narrow pulse pressure, oliguria, rising lactate, and progressive dyspnea from pulmonary congestion. Unlike inferior STEMI, with right ventricular involvement, where preload sensitivity and bradycardia dominate, anterior STEMI patients rarely benefit from aggressive volume loading. Large fluid boluses simply worsen pulmonary edema because the failing LV cannot accommodate the additional preload. Management in anterior STEMI is about supporting cardiac output and oxygen delivery. Carefully titrated inotropes to augment contractility, vasopressors to maintain coronary and end organ perfusion pressure, and early consideration of mechanical circulatory support when pharmacologic therapy is not enough. The cornerstone of treatment is rapid reperfusion. Primary percutaneous coronary intervention, PPCI, is the preferred strategy when it can be delivered promptly, classically within a door-to-balloon time of 90 minutes at a PCI-capable hospital, or within 120 minutes of first medical contact if transfer is required. When PCI will be substantially delayed, fibrinolytic therapy is used as a fallback, ideally within 30 minutes of hospital arrival, recognizing that fibrinolysis is less definitive, has a higher risk of re-occlusion, and should be followed by rescue or routine PCI, depending on the clinical and ECG response. The principle is simple. Time is myocardium. Every minute of LAD occlusion increases infarct size, risk of shock, and long-term heart failure. Even when the epicardial LAD is successfully opened in the cath lab, tissue-level perfusion is not guaranteed. A key modern concept is microvascular obstruction, often called the no reflow phenomenon. In microvascular obstruction, distal embolization of thrombus and plaque debris, along with severe endothelial injury and edema in the microcirculation, prevents adequate blood flow through the small intramyocardial vessels, despite a widely patent stent in the main artery. On imaging, such as contrast-enhanced cardiac MRI, this appears as dark zones of no reflow within the bright infarcted territory. Clinically, microvascular obstruction is strongly associated with poor myocardial salvage, adverse LV remodeling, persistent LV dysfunction, and long-term heart failure. It helps explain why some patients remain hypotensive, in shock, or with low ejection fraction, even after what appears to be a technically perfect PCI. Because the LAD supplies the interventricular septum and conduction system, anterior STEMI has a distinct arrhythmic and conduction profile. New right bundle branch block, left anterior fascicular block, or bifascicular block in the setting of anterior ST elevation is a red flag for extensive septal involvement and proximal LAD occlusion. High-grade AV block, including Mobitz type 2 or complete heart block, can occur and is much more ominous in the context of anterior MI than in inferior MI, because it usually reflects structural destruction of the conduction tissue rather than transient ischemia or increased vagal tone. Additionally, anterior STEMI carries a high risk of ventricular tachycardia and ventricular fibrillation, particularly in the early hours during active ischemia and reperfusion. These rhythm disturbances may present as sudden hemodynamic collapse and require immediate defibrillation, aggressive correction of electrolytes, and optimization of anti-ischemic therapy. Mechanical complications are a feared consequence of large anterior infarcts. Rupture of the interventricular septum leads to an acute ventricular septal defect, with a sudden left-to-right shunt, abrupt hemodynamic deterioration, a new harsh holosystolic murmur at the left sternal border, and rapid escalation of pulmonary edema and shock. Papillary muscle ischemia or partial rupture, although more classic in inferior MI, can occur with anterior infarction and cause acute severe mitral regurgitation. This presents as acute respiratory distress, hypotension, and a new holosystolic murmur at the apex. Over time, large anterior and apical infarcts can organize into dyskinetic LV aneurysms, which predispose to mural thrombus formation and systemic embolization, including stroke. LV free wall rupture, though less common, presents catastrophically with pericardial tamponade and pulseless electrical activity. Echocardiography is critical for early identification of these structural complications. In the modern critical care environment, management of anterior STEMI, complicated by cardiogenic shock, has shifted toward a structured, team-based approach. Many centers use a dedicated shock team that brings together interventional cardiology, heart failure specialists, cardiothoracic surgery, and critical care. Early activation of the shock team for a patient in, or trending toward, cardiogenic shock enables rapid and standardized decisions about escalation. Choice of inotropes, timing of intra-aortic balloon pump, use of percutaneous LV assist devices such as Impella, or initiation of VA ECMO in extreme cases. Rather than a series of uncoordinated individual decisions, the shock team approach creates an organized algorithm for support, weaning, and evaluation for advanced therapies. Invasive hemodynamic monitoring plays an important role in these complex cases. While non-invasive blood pressure and echocardiography provide key snapshots, a pulmonary artery catheter can deliver continuous, quantitative data on cardiac index, pulmonary artery pressures, pulmonary capillary wedge pressure, systemic vascular resistance, and mixed venous oxygen saturation. In refractory shock, this level of detail allows the team to distinguish between persistent pump failure, right ventricular involvement, excessive afterload, or hypovolemia, and to titrate inotropes, vasopressors, and mechanical support in a data-driven way rather than by guesswork. Serial lactate measurements and urine output complement these invasive parameters as real-time markers of end-organ perfusion. Once the acute phase has passed, reperfusion completed, arrhythmias controlled, and shock stabilized, the focus shifts to long-term myocardial protection and prevention of adverse remodeling. Patients with reduced LV function after anterior STEMI should be started on and aggressively titrated through guideline-directed medical therapy for heart failure with reduced ejection fraction. This typically includes a beta blocker to blunt sympathetic overdrive and reduce oxygen demand, an ACE inhibitor, ARB, or angiotensin receptor neprilysin inhibitor. to reduce afterload, limit remodeling, and improve survival. A mineralocorticoid receptor antagonist to further modulate neurohormonal activation. And, in contemporary practice, an SGLT2 inhibitor to provide additional cardioprotective and renal benefits. In patients with large apical infarcts or documented LV thrombus, anticoagulation may be indicated to prevent embolic stroke. Over the subsequent weeks to months, repeat echocardiography helps assess LV recovery, guide ICD candidacy, and refine the heart failure regimen. Contrasting anterior STEMI with inferior STEMI helps anchor the hemodynamic mindset. Inferior STEMI, especially with RV involvement, is preload-dependent and often characterized by bradycardia, AV nodal block, and hypotension that responds to cautious volume expansion, with nitrates used very carefully. Anterior STEMI, in contrast, is dominated by loss of LV pump function, tachycardia, pulmonary edema, arrhythmias arising from septal and anterior scarring, and a high risk of cardiogenic shock. The guiding principle at the bedside is, for inferior STEMI, protect preload and the right ventricle. For anterior STEMI, protect cardiac output and aggressively monitor for shock, conduction blocks, and mechanical failure. In summary, anterior STEMI is a high-stakes event that threatens both the mechanical and electrical integrity of the left ventricle. The clinician's job is to recognize it rapidly on the ECG, restore blood flow with timely reperfusion, understand that opening the epicardial artery does not guarantee microvascular perfusion, anticipate cardiogenic shock, structure management through a shock team approach with invasive hemodynamics when needed, and then transition to long-term, guideline-directed therapy to prevent chronic LV remodeling and heart failure. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.